At birth, a female carries a breathtaking inheritance, 1 to 2 million primordial follicles. Each follicle cradles an immature egg, and together they represent her entire lifetime supply. Unlike many cells in the body, no new follicles are created after birth. This finite reserve is the foundation of her reproductive journey. Yet from the very beginning, loss begins. By puberty, only 300,000 to 500,000 remain, reduced by a natural process known as atresia, in which follicles quietly degenerate. It is a biological pruning that shapes the future of fertility. Each cycle, hormonal cues awaken a cohort of follicles, but rarely more than one completes the journey to ovulation. The rest fall away, unseen casualties of biology selection. Though born with millions of possibilities, across a lifetime only 300 to 400 eggs will ever be ovulated. Scarcity is written into abundance from the start. As the years pass, the reserve not only dwindles but ages. By the mid-30s, mitochondria falter, chromosomal errors rise, and egg quality declines, an invisible erosion of potential. By around age 50, the ovarian vault is nearly empty. Only a few hundred to 1,000 non-viable follicles remain, too few and too damaged to sustain reproduction. This depletion narrows fertility, heightens miscarriage risk, and limits the success of reproductive technologies. Biology whispers that time is finite, but reproduction is more than follicles. It is a hormonal symphony. GnRH from the brain signals FSH and LH, orchestrating follicle growth, ovulation, and uterine preparation. Mid-cycle, estrogen climbs to a peak. This surge triggers luteinizing hormone, unleashing ovulation, the dramatic release of a mature egg. The ruptured follicle becomes the corpus luteum, producing progesterone and estrogen, stabilizing the uterine lining in anticipation of life. When fertilization does not occur, hormone levels drop, the lining is shed, and the rhythm begins again. As menopause approaches, this rhythm falters. Inhibin levels fall, FSH rises, follicle recruitment accelerates, and timing becomes unpredictable. Sometimes follicles recruit too soon, overlapping cycles in the luteal out-of-phase phenomenon, a hallmark of instability. Eventually, the cycles end. Menopause, from the Greek menos, month, and pauses, to cease, marks the final period. By medical convention, menopause is defined as 1 year without menstruation, signaling the irreversible loss of ovarian function. The early transition can last years with subtle symptoms, irregular cycles, restless sleep, the first warm waves of hot flashes. When gaps exceed 60 days, the late transition begins. Symptoms intensify, cycles lengthen, and the ovarian symphony nears its coda. But the ovaries do not retire in silence. Their decline echoes across the body, reshaping bone, heart, skin, and mind. In Part 2, we explore those echoes. From the silent decline of follicles emerges a systemic transformation. The hormonal shift of menopause reverberates through the entire body. Perimenopause is marked by hormonal whiplash. Estrogen swings from highs to lows. Progesterone wanes as ovulation falters. These shifts bring irregular cycles, hot flashes, and night sweats. After the final period, estrogen stabilizes, but at a fraction of its former levels, while FSH and LH remain high, searching for ovaries that no longer answer. Without estrogen, bone resorption accelerates. Within a decade of menopause, women can lose up to 20% of their bone mass, dramatically raising fracture risk. Estrogen once guarded the heart, keeping vessels supple, lipids favorable, and inflammation low. Without it, arteries stiffen, blood pressure climbs, and cardiovascular disease risk rises. Estrogen supports neurotransmitters, blood flow, and plasticity. Its loss brings forgetfulness, reduced concentration, slower processing, and mood changes that color daily life. Some evidence links reduced estrogen to greater risk of Alzheimer's disease, though research is ongoing. What is clear? Cognition and mood shift in complex personal ways. In the pelvis, estrogen decline thins tissues, reduces lubrication, and weakens pelvic muscles. Dryness, pain, infections, and incontinence often follow. Skin too reflects the change. Collagen production drops, hyaluronic acid falls, leaving skin thinner, drier, and less resilient. Metabolically, fat redistributes to the midsection, insulin resistance grows, and lipid profiles worsen, fueling risk for diabetes and heart disease. Genetics shape the risk, but choices matter. Exercise, nutrition, sleep, and stress management reduce the burden and restore strength. Medical tools, local estrogen therapy, pelvic strengthening, lifestyle interventions offer relief and restore quality of life. But when symptoms persist or risks climb, therapies step forward. In Part 3, we explore how hormone replacement, non-hormonal drugs, and lifestyle care transform health after menopause. After the story of biology and the cascade of effects, the final chapter is treatment. Nearly 40% of a woman's life unfolds after menopause. Care must be personalized. Hormone replacement therapy, or HRT, remains the cornerstone. It relieves hot flashes and night sweats, improves sleep, restores intimacy, eases urinary symptoms, and protects bone. Oral estrogen is effective, but passes through the liver, boosting clotting factors and raising the risk of thrombotic events, especially in older women. Transdermal estrogen, via patches, gels, or sprays, bypasses the liver, lowering clotting risk and providing steadier hormone levels. For women with a uterus, progesterone or progestins must accompany estrogen. They protect against endometrial overgrowth and cancer. Therapy can be continuous or cyclic. The aim: balance benefits, minimize risks, and match the rhythm of a woman's life. When hormones are not an option, non-hormonal drugs help. SSRIs, SNRIs, gabapentin, and clonidine all reduce vasomotor symptoms. Cognitive behavioral therapy, acupuncture, and lifestyle strategies like weight control, cool environments, and stress management add further relief. New therapies like fezolinetant target neurokinin receptors in the brain's thermoregulation center, reducing hot flashes without hormones. Drugs like bisphosphonates, SERMs, denosumab, and teriparatide protect bone. Calcium and vitamin D remain essential building blocks. No single plan fits all. Age, timing, cardiovascular and cancer risks, symptoms, and personal values all guide the choice. Therapy evolves with life. Regular reassessment ensures safety, effectiveness, and balance. From birth's first follicles to life after the last cycle, menopause is not just an end but a transformation. With knowledge, medicine, and care, women can thrive in every stage of life.